ultrasound, plasma exchange, serologic testing, potentially the utility of tocilizumab. So very exciting things, very excited about that. One other thing that we were going to talk about, I don't know, Brandon, are you on the line? Maybe not quite yet, but Brandon Bookstaver was going to be talking about a registry that we're going to be doing here to try and look at folks who have had coronavirus, who we're following up over time to see what kind of medications they've been on and what the outcomes were for those individuals after they'd presented to the hospital or a clinic, and how they did with the medications they were on. Because I feel like there's still a lot of questions about medications that we don't have great answers to. So that should be very interesting. Once he comes on, I'll let him give like a 2 minutes about kind of what we're going to be doing with that. Just reach out to you folks, so potentially you can help us gather this data, which could be useful. I think that's important as well. And I think hopefully moving forward, we'll be able to talk a little bit more about things like serology in terms of its utility for immunity, and whether or not we're going to be needing PPE as much, or people will be able to come out more if we have positive IgGs. I feel like those are things that are not quite known yet. But I kind of wonder to you folks, before we get going here, you've seen what we're going to talk about. What things do you wish were on this list that you would like to see at the next Citywide or talk about? Are there any particular topics that you feel like are coming up that you want to hear about? Folks, I think that's good. I think that's good. We're coming up on 6:30, so I'll kind of leave it at that. I see that Dr. Bookstaver has joined the meeting. Brandon, are you there? Can you wave at me? Can you hear me okay? Oh, fantastic. Wonderful, wonderful. So if you could, I'm going to give you a minute just to chat about this registry that we're putting together and kind of share what's going to be going on with that, if that's all right with you. Brandon, can you hear me? Okay. Do you want to talk a bit about the registry? Sorry, the audio, it's still muted, I think.
I think you may be trying to call in, possibly.
Oh, I'll take it. Yeah, improvise, adapt as we come. All right. I'm called in. It says I'm muted. How do I unmute you? Let's see here. Let's see here. All right. All right. Any luck? Sorry, Brandon, I'm not sure.
Now I'm unmuted.
Sure. Oh, yes, perfect. Excellent. All right, sir.
Awesome. Thank you very much. I'll since you gave me 2 minutes and I just wasted one, I'll get it done in a minute. No, we appreciate the opportunity just to share briefly for those that are on the call. We have embarked, and I say we, there's a core group of investigators from a number of institutions represented across the state, including regulatory bodies like DHEC, that are embarking on a statewide COVID-19 registry. And the goals really broadly are to be able to track not only the management and treatment strategies that have been employed in hospitalized patients, whether you're ICU or not, but also to track short and long-term outcomes from the therapies that are utilized. We really are trying to differentiate ourselves a little bit by tracking safety as well as effectiveness, something that we feel that because of the geographic variations across the country and certainly across the globe, having something that is specific to our state will really give us an opportunity to measure things that could easily be impacted by our particular population, our underlying healthcare system, and certainly the strategies that were put in place and the timing of those. So we're excited for this. I told Edwin that I would send out our overview document. We're currently at the stage now where we have a third draft of our data dictionary. And so this is going out for final approval. And at that stage, there will actually be a website that we will be able to engage acute care institutions across the state to utilize a REDCap HIPAA-compliant shared database to participate in this statewide registry. So really excited about it. Again, stay tuned to your emails. I'll try to get it out to you during this call so you'll have something afterwards to look at, but certainly, and we'll include everybody's contact info. So if you have suggestions, recommendations, or you're interested in further collaboration, we certainly will welcome it. So thank you very much. And you're now muted, Dr. Hayes.
Look at that, tit for tat. Okay, thank you, Dr. Bookstaver, very much. If you want to put potentially your contact info in the chat, maybe so people could better reach out to you, then that would be helpful. But I do appreciate it. I think we're going to go dive into the scheduled presentations now. First on the list is Dr. Eric Meisner to give us a little bit of an update of what's happening at MUSC. Dr. Meisner, you have the floor, or the phone, the computer.
All right, can you see my slides?
Yes, I can.
Great, so hello. Having never participated in this, I'm super pumped to go first. I'm Eric Meister. I'm a infectious disease physician down here at MUSC. What I thought I would do is just sort of give the mile-high view of our current epidemiology here, make a few points about some of the stuff that we're up to, and then just open it up for discussion. And so, yeah, just to start with, this is from our division director, Dr. Salgado here, just you know, so in Charleston, what's going on with our epidemic? And I just start with some basic epidemiology. And so what you can see is, you know, we had end of March, early April, we had obviously a large increase in cases. Things have definitely leveled off some since then. In the blue is our total confirmed cases. And then in the orange below, as I'll show you in the next slide, is new cases. And so initially our surge, and it may still be true, initially our surge was sort of scheduled for the end of April, if you will. But here we sit, and that hasn't sort of taken off as expected yet. So here's our new cases, and the arrows. I think the 15th is when my wife was forced to homeschool our 3 children when the schools closed here. I think the 25th was, and then the 6th were some of the more, the business closing, and then the self-isolation guidelines. And so we definitely had more cases, new cases earlier in April, and the late April surge, at least thus far, hasn't happened, although it's still predicted. Here's a little bit just about our characteristics. And so we have the main campus here, which is where I work. We also have Florence, Lancaster, and Marion. You know, we've had actually, you know, I don't work there, but there's been more admissions in Florence than here at MUSC in Charleston. I think just a couple of points here are for those patients that are hospitalized, about a third are being intubated. And we were sort of a standard of care treating with azithromycin and azithromycin and Plaquenil sort of from the get-go. Our treatment guidelines are being adjusted with the recent data, such that that's less likely to become as standard as it has been at the get-go. And just a little bit about our employees. And so that's one window into our epidemic here. And this sort of mimics the graph I showed you already. So in blue, this is our total number of MUSC employees with confirmed diagnosis. And then in orange is when it happened. And so we had a bolus there in mid to late March. And the epidemiology, again, this is not my work. This is the work of our Scott Curry and Castiel Salgado, but the vast majority were either travel related or community related, and only a paucity were potentially work related with exposure to a colleague, and then some sources were unknown. But as you can see, this is like the epidemic in the city. This is sort of leveled off based on this data as of late. So again, this may be boring to you, but one of the ways we keep track of this is our dashboard in Epic that we're able to sort of follow. On the left, what you can see, a lot of our testing here is to the drive-through testing site in West Ashley. And so we route folks to an online questionnaire that if they meet criteria, they're directed to the testing site. And you can see the frequency of testing has gone down as of late. In part, this may be due to availability of testing elsewhere. And in part, this may be some reflection of the epidemic. On the right, what you can see is the folks that are currently hospitalized at the main MUSC campus that are currently being ruled out for COVID. We have about a 24-hour turnaround time with the internal PCR testing. And then we have our number of COVID positive folks there shown as well. And so this is just one way the physicians can sort of keep track over time. And to everyone's enthusiasm, that number has not taken off as was feared. Another way we look at it is, and so this is of all the people that are tested, the percent positive. And so we're doing all sorts of stuff here, like testing folks routinely pre-procedure and in the inpatient setting. And so there's a lot of swirling testing approaches going on. But if you ignore all that, the noise for why someone gets a test, our percent positivity has sort of remained around 6%. And then what I'll close with is a study that I'm leading with others. And so, our clinical lab, as is true, I know from many of you, is currently knee-deep in validating the Abbott and planning to take on the diasorin assay to do nucleocapsid and spike protein serologic testing. One thing I'm working on with a great team of people is a population seroprevalence study. I'll just tell you about it briefly, then happy to answer any questions. We're using a FDA approved for marketing, but not FDA approved, not FDA reviewed point of care IgG kit. It has some sensitivity and specificity questions, which you can talk about. But the study is basically we're enrolling our own, so we're enrolling 440 employees. One cohort is quote unquote high risk folks. And so these are folks that either work at the screening site, the emergency department, or who have provided care for a known COVID patient, or who are involved in aerosolizing procedures. We're also enrolling 100 folks not involved in direct patient care. We started enrollment last week. It was filled in 3 days, and we're working through the electronic consenting. The way this works, we send out a recruitment email. We then assess eligibility over the email. We do e-consents with a team of study coordinators. We partner with the pharmacy to mail these kits. We provide instructions, which I'll show you in a second, is easier said than done for how to perform this test in a place it's not supposed to be performed. And then we're going to repeat this up to 4 times every month. And so this is what the kit looks like. The pink is the Lancet, the alcohol prep, and the Band-Aid are obvious. You basically, within the silver packet on the left, there's a strip, which I'll show you, and a pipette. The subject makes the finger prick, sucks up the blood with the pipette, puts it in the diluent in the tube at the bottom, and then applies it to the strip. And so this is what the strip looks like. This is a positive result done using serum, so it's beautiful. Done using serum from a patient with known prior COVID infection. The sample is applied to the S. The top line is the positive control, and the bottom line is the test. Like a pregnancy test, this would be a positive result. Again, we could talk about false positives and false negatives, but this is the overall principle. Here's an example of a test using whole blood. It's now red because we're not using serum. What you can see is a positive control. You can also see some red creeping up from the bottom, which has proven an interesting issue. And this would be a negative test with no line seen at T. About a quarter of our samples thus far, we're learning on the fly, have this particular issue, which again, I can talk about in detail if there's interest. But due to the use of the whole blood and the way the assay is sort of run, there is a potential for this artifact to affect the results. But now that we're aware of this issue, we know how to mitigate it. And here's an example of how you can still sometimes make some sense out of it, even when it's messy. And so this is a test from whole blood of a known prior infection patient. And so even though there is this artifact in the background, one can still appreciate a positive band there. And so, like I said, we're sort of learning on the fly with this test, trying to establish some sort of principles for how to do this sort of work, appreciating it's not a perfect test. And with that, I'm stopping, happy to answer any questions.
Any questions for Dr. Meisner?
Eric, Robert Ball here. Quick question. Sensitivity and specificity. I came in late and I may have missed that. Your IG and the IgM.
Yeah. So you didn't miss it. I glossed over, but yeah. So what we decided, we wanted to steer clear of the IgM. It's just messy on top of messy. And so we enrolled people that were at least 14 days out from anything. So we're trying to stay out of active infection here. The sensitivity is poorly defined. There is data on less than 100 people. That's part of what they put out. But like many of the tests, it's maybe 90% sensitive-ish, plus or minus. But it's not really enough in to sort of write your mom home about the number. The specificity is a issue as well. It's not been tested against cross-reactivity against other circulating community coronaviruses. For example, coronavirus NL63 on our respiratory viral panel here in February and January was not uncommon. This test has not been tested against samples from patients who had known infection to determine if that would be a false positive. Having a week of experience under my belt with this test now, I'm officially more worried about sensitivity than specificity, but we're just getting started here and we just have to see. I will mention also our lab colleagues, they're full force ahead on the clinical test, which this is not, but they're trying to help us do some validation work using this kit with some leftover waste samples sort of next to the validation they're doing for some of the other assays. But in summary, there are definitely sensitivity and specificity questions. There's more information that will be needed. You know, it's unclear if this kit will ever even be FDA approved for clinical use or if it'll sort of move on. But we wanted to start a study like this sort of because we had access to this. And it's a research study. This is not there's nothing that goes in the medical record here. We have about 100 disclaimers about misinterpreting it as part of our informed consent. And so it's sort of an attempt to do a seroprevalence study with a reagent we had available with acknowledgement of the limitations with regards to sensitivity and specificity. I was not expecting as much technical difficulty with the assay, but I think we sort of got that figured out. and are trying to reduce the frequency with which the fourth image there happens.
Thank you.
Yeah, I think that with diagnostic testing looking at sensitivity and specificity, it's kind of an interesting chicken and egg scenario, because some of what dictates sensitivity and specificity for a test is the prevalence in the community. And part of what these tests are doing is trying to figure out what that prevalence is. So it's, you know, some of it depends on how confident you are that you know what the prevalence is in your local population for how sensitive and specific the test is.
That is the absolutely key, and you have to remember you know, a lot of this original testing, you know, was done in Wuhan, not with this particular one, but yeah, if you're in a scenario where your prevalence is through the roof and there is no other community coronavirus there, you can feel pretty darn confident about it. But yeah, if you have even if you have 95% specificity, if your prevalence is negligible, then you're still looking at more false positives and true positives. And so you're absolutely right. The true prevalence is what's really going to dictate how much the limitations of these tests come into play. And if it doesn't take off as predicted, then yeah, we'll be in a scenario where we'll be more likely perhaps to be misled. That's why the validation work, I think, is so critical, and which is lacking even for the Abbott assay. I mean, a lot of the ones even that are moving forward, none of them are like perfectly validated to the extent that one would want. So yes, prevalence is, especially for people when I logged on, especially when you're talking about use of these tests to make some sort of decision about something. The true prevalence, to the extent you can tell, is a key part of the conversation.
Dr. Meissner, I don't know if you can hear me. This is Jerry Gibson. I came in late, so I may have missed this. Did you think about including a third group of recovered people with demonstrated COVID, which I'm sure there are plenty of in Charleston at this point, and getting some idea on your own of activity at this point?
Yeah, the 2 points there, absolutely. So the way we designed the study, number one, we wanted to stay out of the active infection space because we don't want to do that. And so we allow folks with known previous documented PCR infection to enroll in this study. For example, the last figure here is an example of someone like that. And so within the study, we're hoping to get some sort of internal rough validation that if you were infected before, this test should be positive if it's a real test. And then over time, we're curious to see if the test stays positive or becomes negative in those folks. In parallel to that, with the clinical lab, just because the majority of this study is going to be folks that have not had prior infection. With the clinical laboratory, we're trying to do some rough validation of the kit using samples from PCR positive folks. So absolutely.
Great, thank you.
And to follow up on Edwin's point, in a setting where the population prevalence may be super low, which would be great, doing some of that work in a cohort of people that are legit proven infection is definitely the way to go to understand the test better. Doing this test on a population with low prevalence is a terrible way to weigh in on sensitivity and specificity of the test. It's not the way or approach to do that, and certainly not the intent here.
Well, thank you very much, Dr. Meissner. I think for the sake of time, we're going to go on to our next speaker, Dr. John Schrank, and we're going to travel from Charleston to Greenville to hear a little bit about how things have been going up there. Dr. Schrank, do you want to go ahead?
Sure. Let me So can everybody see this, or?
I can see it. Yes, sir.
Okay, okay. So real quickly, along with, as Dr. Meisner presented, some numbers from the upstate. As far as Prisma Health Upstate goes, as of today, we've tested about 7,300 patients, and you can see 727 positive, 9.8, almost 10% positive. The admissions, the data I'll state from the beginning. A lot of the data I got from various sources through infection control and another dashboard, so I can't speak to the verifiability of it. But as far as Prisma Health Upstate, we've had around 100 admissions and a total of 5 deaths. Just to give you an idea of the county, the numbers I took from the Hopkins website, the total number of positive cases, you can see 517 with 11 or 12 reported deaths. That corresponds to what the DHEC site is reporting. And then just internally within both Prisma Health as well as some data from St. Francis, we have about 727 positive cases and a cumulative number of 155 hospitalizations here in Greenville County with 12 deaths.
I believe that we're only seeing the title slide. Are there other slides?
Yeah, I'm sorry.
No, I apologize.
You're not seeing that slide, or?
I'm controlling Dr. Schrank's slides. I can give him remote, or do you want to control them?
No, that's all right. If I can tell you the next, okay. Can you go to the next slide?
It's not going. Let's see. I'm going to see if I can give you, if you can control it and see if it will advance for you.
Okay. See if I can figure out how to do this.
Okay.
Okay.
I can see the change slide now.
Okay. Okay. So there are the numbers as of today. Like I said, 7,300 patients.
Sorry.
I'm still not controlling my slides here. Somebody else is controlling the slides.
Sorry.
That's all right.
Okay.
That looks good.
Okay. I'm still. Okay. Let me just move on. So total 700, this is directly from our dashboard. As I mentioned, taking comparative numbers, whether you look at the Johns Hopkins site, which is a day behind us, there's a total of 517 cases here in Greenville County, which corresponds to what the DHEC is reporting. And then the data for the total number of cases internally is from Prisma. As you know, Prisma Upstate includes hospitals in Oconee, Pickens, as well as Lawrence County. So when I take the total of that reported through DHEC, I come up with a very close corresponding number of 730. Between the two hospitals here in Greenville County, that is primarily Greenville Memorial and St. Francis, there's been a total of 155 hospitalizations, and the number of deaths in the county is 12. As of today, there are 9 patients that are intubated, 6 here at Greenville Memorial and 3 at St. Francis. This gives you a quick look at, and again, I apologize, the data was collected from various sources, and sometimes it doesn't make sense even when I tried to figure it out. The 100 patients that we've admitted, as you can see down at the bottom, our North Greenville LTAC is actually the primary hospital, and these are data collected at least a week ago when we only had 6 patients. Currently, as of today, we have 25 patients up at North Greenville. This also gives you a snapshot of the spreadsheet, which you can see is very confusing to try to delineate what's actually happening here in the upstate because it's hard to pull out the patients that are positive versus the patients under investigation. And you can see the curves, and I'm not really sure how accurate those numbers are. If you look here, it seems to be an uptick in the last 2 to 3 days of hospitalized patients. But again, we've had over the past week or so between 20 and 30 across Prisma Health hospitalized. Let me go on to the, so what I basically did this morning when I had time is just pull up Epic and did my own data extraction of the 31 patients that were there. And you can see the 31, 55% male, 45% females, the mean age 61. There were 11 total intubated over the course of the hospitalization. 6 are currently, 5 are extubated. About 2/3 were positive on the day of admission. The remaining 11 or 12 were positive anywhere from 1 to 11 days, with the outliers being more 2 nursing home patients that were positive 8 and 11 days respectively, and then developed progressive respiratory symptoms and then were admitted. As far as treatment done in those 31 patients as of today, 7 patients did not receive any specific therapy. The 7 patients received a combination of hydroxychloroquine and azithro. 17 patients had the zinc combination with the hydroxychloroquine. And of the 31, 3 additional patients received systemic steroids. 1 patient that is hospitalized now received tocilizumab. There was also another patient at St. Francis that is also at St. Francis and has also been extubated. And a 3rd patient that we administered expired. So in summary, we've used approximately treated 83 patients with the hydroxychloroquine, either with the azithro or the zinc combination. And most of us feel that it's not really doing much of anything. The tocilizumab, as I mentioned, 3 patients have received this so far outside a clinical trial. The convalescent serum, we've had 2 patients. 1 actually received the serum today, and we're getting ramped up to administer more serum over the next week. The patients up at North Greenville. Right now, we have plenty of hydroxychloroquine available, and we also have approximately 24 doses of tocilizumab as well. What we don't have yet, and hopefully soon, is the remdesivir. We are finally got a site number today, and so hopefully in the next week we'll be able to enroll some patients. Another trial that is hopefully set to run in the next week is a trial headed by one of our oncologists, Dr. Larry Gluck. And I think the idea for this study came to him with one of our first patients that was admitted about a month ago who had myasthenia gravis, and was actually admitted in a myasthenia crisis and required immediate intubation. He obviously did not receive any specific therapy targeted against the COVID-19 virus, but received about 5 treatments of plasma exchange and did very well and was extubated on hospital day 5. So the idea with this is to enroll 20 patients, and the first 10 patients will receive just therapeutic plasma exchange, and the second 10 patients will receive a combination of the plasma exchange in combination with, and I can never pronounce these, it's Jakafi, which is a tyrosine kinase inhibitor, to be given concomitantly. And the idea is that with the plasma exchange, you remove the cytokines that are there, and with the ruxolitinib, you actually block production. So again, this protocol has been submitted to the FDA, and Dr. Gluck is awaiting approval. Hopefully in the next week or so, he'll be able to start this trial up. Again, it's just a pilot trial involving 20 patients. And I think that, yeah, the last slide I have is the drive-through testing. And as you can see, it's got its ups and downs. My guess is the downs are mostly when we've run out of reagent or testing. Overall, it's been fairly steady, except for the one bump in early April. And I think that's the last one slide I have. And sorry for the technical glitches, but be happy to answer any questions.
Any questions for Dr. Schrank? Dr. Schrank, I really appreciate you coming out to speak. I'm very hopeful that you'll have remdesivir soon. We have been giving it here a bit. It's been difficult because the criteria for people enrolling are a bit strict. And I'm not sure what kind of outcomes we've been seeing from it. I'm very interested to see what the final results are on that. We have been seeing a bit of LFT elevation in general, not so much in our population, but in the safety reports I received from Gilead. I'm glad that we're finally getting you folks in there. You've been doing good efforts to make that happen.
Hopefully, yes.
Okay, well, again, thank you very much, Dr. Schrank. Thank you, Dr. Meissner, both for kind of reaching out from out there and letting us know what's going on in your neck of the woods. And then we're going to transition a little bit to what's going on in Colombia, particularly in some of the experiences we've been having here. And the next talk is going to be from Dr. Perez, Dr. Keith, and Dr. Day, talking about at Lexington what they've been doing with plasma exchange therapy. Would you gentlemen like to move forward?
All right. I'm going to share the screen, and hopefully the slides will be advancing, but if not, let me know, and we'll have to make some adjustments, I guess. So can everyone see the screen?
I can see you.
Okay, let's see. Let me try again. Share screen. Can you see it now?
Yes, now I can see.
All right, good. So I'm just gonna give a little introduction, kind of like an appetizer, because I'm just gonna present a case, and then Dr. Keith and Dr. Day, which are two-day intensivists at Lexington, will be talking in more details about our experience with plasmapheresis. This is, just basically a few slides to summarize the case. So one thing I want to report, there's some anecdotal evidence of the accelerating aging effects of COVID-19. I kind of experienced this myself. This is me before COVID. I was a smiley middle-aged person with a beard. And this is me after COVID, which, I had to lose my beard to fit my N95. I lost some hair and I gained some weight. So this is ready for publication soon, but so you guys get a preview. Anyway, this is the case that I want to present, and then Dr. Keith and Dr. Day will give more details about the plasmapheresis. But this was a 67-year-old male, came from an extended care facility, and we have had an outbreak in that facility. So actually, he was tested on March 17 as part of a surveillance that we did in the facility, and was at that time negative. He has some comorbidities. You can see them there: cerebral palsy, diabetes mellitus, and history of urinary retention and UTIs. So, about 9 days after that negative COVID test, he developed some fever, shortness of breath, and some respiratory issues in the nursing home. So he was admitted to the hospital, and at this time was positive for COVID on this date on 3/26. He was at the time also co-infected with a urinary tract infection by Pseudomonas. So after admission, we put him on treatment with hydroxychloroquine, Plaquenil and azithromycin. He completed the 5 days of treatment on the 31st, and he was on treatment for the Pseudomonas with cefepime. This is the X-ray. This goes from right to left. I'm sorry, but that's the only way that I could put this up in our system to put comparison X-rays. But on the right is the X-ray on admission on 3/26. There's some interstitial markings that that are not that impressive. Then by April 2nd, at that point, he had been already transferred to the ICU. You can see he had some significant changes on the lung fields on the X-ray. So his deterioration in the hospital started around March 31st, and that's when he was transferred to the ICU. He continued to get worse, requiring increasing FiO2. And then, after a few days in the ICU, we tried tocilizumab, the Actimera. We gave him 2 doses, one in April 3rd. We repeated the dose in April 5th because he didn't seem to be improving. We sent that interleukin-6 that is recommended that you send before treatment, and it was elevated. It takes several days for us to get the results, so it didn't really change what we were going to do anyway. But at least there was some elevation of the interleukin-6, and this tocilizumab seems to be an inhibitor of that particular cytokine. So after the 2 doses of tocilizumab, he was not really improving. So we decided to try a third thing, and at that point, on April 6th, we started with plasma exchange or plasmapheresis. The Dr. Keith and Dr. Day may talk about this more, but one of the things that we've seen in these patients with COVID that are, critically ill is they have issues with clotting and coagulation and problems of that nature. So he actually requires several catheters to get his plasmapheresis done. He got a total of 4 plasma exchanges. Some of the things, I put some of the labs there, but on the day he started the plasmapheresis, I don't know if you can see the cursor here, the D-dimer was very high, 25,000. That's, that's the highest I ever seen a D-dimer. And, from the effect of the plasmapheresis or the treatment, or, you can see those D-dimer levels were decreasing. His CPKs were not really that impressive. They didn't really change that much through the course of the hospitalization. The LDH, which is another parameter that we've been following in some of these patients, also didn't really have a very significant increase. And the C-reactive protein levels, in spite of the plasmapheresis treatments, they remain elevated, but you can see there was definitely an effect of the plasmapheresis in decreasing that inflammatory marker. Like from a couple days before, the plasmapheresis was in almost 300, and after he completed his treatment, had gone down to 9.5. This is use a table with some of the other parameters kind of compiled in a maybe easier way to see. It's a busy table, but I think one of the impressive things there is the significant decrease of the D-dimer with the plasmapheresis. Whether some of that is, the therapeutic effect of it or not is, I guess, remains to be seen. So after those 4 days of plasmapheresis, actually the day after the first plasmapheresis, so he had the first dose first treatment on April 6. The next day he was extubated, so there was a significant and rapid, potentially effect of the plasmapheresis. He continued to improve. His X-rays continued to look bad. You see an X-ray there on the 13, where he still has significant changes. That in spite of his improvement, was kind of lagging behind. We've been doing COVID tests to try to get him out of the COVID unit. and he's had repeat testing many times that is still positive. I'm sure that some of you have seen the same thing. There's some people, especially those sick ones that require ICU care, that continue to have this positive PCR, and whether that means this is live virus or this is, you know, dead RNA that we're detecting, I guess remains to be seen as well. He's still in the ICU, but it's because of AFib and some tachycardia related to that. We're still waiting for the negative PCR to get him out of the COVID unit. And eventually, I think he'll transfer back to the ECF because he's extubated, you know, he's on room air and doing very well at this point. So those were a few, you know, the slides I wanted to present. It's kind of the appetizer. If, you know, you're gonna get the main course from the doctors, so you can enjoy it as long as you can eat with a mask, because that's kind of the weird times that we live on nowadays. All right, you can, I don't know how to remove my slides or kind of get back, but you can block me or whatever.
Do our slides show up now? Can everybody hear us?
Yes.
I can hear you.
All righty, thank you. Thank you, Dr. Perez. I'm Philip Keith, this is Matt Day. And Dr. Perez was actually the main event. We're here just to follow that. And I would add that patient, we're keeping him in the ICU just because we've gotten attached to him and we want to discharge him to extended care. So kind of going back to our idea for plasma exchange for COVID, it really starts with our interest for plasma exchange for sepsis with multiple organ failure. And though there's limited data, we've had good anecdotal experience with this in our training and previous experience. From the American, you can consider apheresis, plasma exchange in patients with sepsis and multiple organ failure, but it doesn't really define that organ failure. What we're trying to treat by using plasma exchange is this vicious cycle that happens where you get the cytokine storm that leads to widespread dysfunctional inflammation, dysregulated inflammation, which leads to capillary leak. And activation of the endothelium, which leads downstream, I think, probably most importantly, to pathologic coagulation in a picture that's similar to TTP, forming microcirculatory clots throughout all the organs. And so the person I learned from summed it up as saying that basically what we're dealing with is TTP induced by sepsis. The hard part is identifying which patients need to be treated, which patients are going to get better without it, which patients would likely benefit. And through our normal septic patients, we've developed sort of things we look at that are evidence of end-organ malperfusion. We look at lactate, lack of lactate clearance. We look at pressure needs for sure. We look at thrombocytopenia, various independent factors that are associated with poor outcomes. And so when we think about treating patients with COVID that present with sepsis and multi-organ failure, we want to identify those patients, but obviously there's no experience with it specifically for COVID. And of course, we don't want to do any harm. So the pros of plasmapheresis, as we see it, is that it does transiently lower those levels, including interleukin-6. Various investigators have shown decreased levels. It's a non-specific removal of cytokines. We're not directed at one. It's sort of an all or nothing. It does tend to stabilize endothelial membranes when you use plasma as the replacement fluid, which leads to stabilization and decreased capillary leak. But again, I think most importantly, it helps to reset that coagulation cascade that's out of whack. It removes the large protein multimers that are implicated in the clots that have actually been seen in some cases of autopsies, both with sepsis not due to COVID and COVID cases in 3 cases that have been reported. It helps to remove the procoagulant factors and replace the enzymes that help with cleaving of those large proteins and help to reset that perfusion. The cons are just as we spoke. You know, we're created with this inflammatory response, and obviously some of those mediators are likely helpful, but we feel like the net effect may be that it helps individual patients. Another big question that comes up is, are we removing those antibodies that our body's forming to protect us, which leads to further downstream question, because with bacterial pneumonia, with influenza that we've treated this previously, we get source control. If we're removing the antibodies that we're creating with plasma exchange and we don't really have good source control with the virus, what is the net effect of the plasma exchange? So our experience prior to COVID, without going into specifics, is what we've seen and what we judge as a favorable outcome is that hemodynamics improve within 24 hours of the first treatment. That's almost universal with the patients we've seen, even in the patients that ultimately didn't survive. We see hemodynamic improvement. We see improvement in their organ function in the way of improved creatinine, improved mental status, improved P to F ratios. These haven't been analyzed, but just on our experiences over the last 4 or 5 months. As they come off pressors, we obviously are able to obtain a favorable fluid balance, and all these things are associated with better outcomes. We're not comparing these patients to others, but we feel as if by getting them off the ventilator, getting them off pressors, recovering their organ function, they're leaving the ICU earlier, they're leaving the hospital earlier. And so our bias is that these patients are having better outcomes and shorter needs with decreased morbidity. So our question when COVID started to come in is we believe this pathophysiology is the same, and it does appear to do so. Dr. Perez talked about the labs we're tracking, and those serve as markers to us. There's a pronounced cytokine storm and inflammation, which we try to judge by the CRP levels and the ferritin levels. There is a microangiopathic hemolysis and clotting that goes on that we're Can everybody hear me?
I can hear you now.
All right, sorry. Our computer died. We're on call here at work. So I lost our slides, but let's see.
I can see you too.
You can see, okay. Let me unmute. Let me mute the picture then.
Oh, and now I'm seeing the slides. Now I'm seeing the slides.
All right. All right. So we got it up and rolling. Sorry about that. All right. So when we started having an increased volume of critically ill patients with COVID, like Dr. Perez, we were seeing patients that didn't seem to be improving despite what we're doing. And so our belief is that sepsis that's caused by COVID is due to that same cycle of inflammation, endothelial injury, coagulopathy that's common to other causes of sepsis. So as our first patient came in and met those criteria of hypotension, lactic acidosis, thrombocytopenia, new onset heart failure, respiratory failure, that was our first experience, and it turned out, no, it's okay. It turned out to be a favorable one. She was able to leave the hospital, never required intubation. The patients that we've had in follow-up, we've had a total of 6 patients that we, based on our definition of sepsis with organ failure that's progressing, which is a fluid definition, we've treated 6 patients so far. Of all 6 patients, their hemodynamics all improved with treatment. 4 of the 6 patients were intubated at the time, and all 4 were ultimately able to be extubated. Our sickest patient, who who I believe is having the worst case because of his underlying lupus. He was extubated for 5 days with single organ failure for those 5 days. He's since declined and had to be reintubated and has had progressive shock. He got another round of plasma exchange. Hemodynamics improved, but he appears to be in a fibrotic stage of ARDS at this point, unfortunately. The fifth patient, the other patient that was not intubated was the one we first described that had new onset heart failure, shock, multiple organ failure. Each patient, including the gentleman that declined subsequently, showed improvement of end organs damage in the way of renal failure, hemodynamics, other markers, thrombocytopenia that may have been down in individual cases. And the one gentleman that required renal replacement therapy has since recovered and no longer dialysis dependent. Dr. Perez showed the markers on the patient, and that's been a consistent finding. So each of the patients have shown improvement. The one thing that we have seen is that, and here's just a slide to sum that up, the hemodynamics, the organ failure, apart from the lungs, have certainly been consistent. The thing that lags behind is the respiratory failure and the ARDS. And so this is certainly encouraging. It's a very small body, but plasma exchange alone is probably not the only answer. It's certainly not the answer for every patient, but we've been encouraged by the results in sepsis in select patients, and our experience with COVID so far has been encouraging as well. We have just been approved for convalescent and gave, I saw the question pop up. I do think that something targeted towards the virus itself is key to this, because this plasma exchange sort of stabilizes the organs, but it doesn't lead to more rapid resolution of the inciting event. And so we are excited about plasma exchange coupled with convalescent plasma as a potential therapy that together might help this resolve quicker. And so that's sort of what we had to present, and happy to answer any questions or suggestions y'all might have.
Any questions? I think Dr. Albrecht's question was certainly a pertinent one there. And then as Dr. Schrenk had mentioned, that they're working on upstate about adding something to potentially suppress the inflammatory effects after the pheresis. It's an interesting idea. There could be synergy.
I was just going to ask that, timing, if you're going to do the two together, the timing of plasma exchange and sera, because you obviously don't want to give exchange it.
Yeah, convalescent would be after the pheresis. If you do this every day, then obviously that doesn't work. But after the last one, whatever the last one is, but I think it would actually be potentially synergistic.
Hearing whispers.
Are you not muted?
Okay. All right. Thank you, Dr. Perez, Dr. Keith, Dr. Day. Really appreciate you coming and talking to us about that in the midst of working. Very kind to do that. And we're all in the midst of working, it seems like constantly now. So thank you for coming out and talking. Going to transition on to our next speaker. Yes.
Hello, all. There are two voices. Two voices there. Sounds like Jerry Gibson in the background.
Not me.
Can everyone hear me okay?
We can hear
Yes.
Excellent, excellent. Okay, so as I said, I'm going to go ahead and turn it over to Dr. Olatosi, who's graciously come back to speak. He spoke last month about what's happening in Kershaw, and now he's going to talk a little bit about his experience with serologies and antibody testing. Dr. Olatosi, thank you for coming. Dr. Olatosi, I believe you are muted.
Can you hear me now?
Yes, yes, I can.
Oh, thank you, Dr. Hayes, for letting me come back and talk again about our experiences at Kershaw. We feel much better now. Things look better. For the past 3 or 4 days, we've not had any cases since Friday, 0 cases. So we're hoping that will be maintained. And we are following it up because the other differentials for that is that maybe they went somewhere else. But the way DHEC reports the report, it's based on your county address. So if you're still coming from Camden, even if you go somewhere else, it will show up on your county address, which we've not seen. So with the new lease of life that we're getting, we started thinking about what else can we do. And we've been thinking about this for about 3 to 4 weeks ago, that what do we feel we can use antibody testing for? And this was actually prompted by vendors just coming in and bringing in all sorts of antibody tests, wanting for us to acquire and use on our population in Camden. So we kind of went through some of these tests, read their information pamphlets, and also had some discussion with other colleagues to see really what role should these tests play. I mean, the FDA has approved over 70 vendors for these tests. So that's kind of in a way to show you what's been going on. I don't seem to be able to move my slides. I don't know why that is so. Okay, so Kershaw County contracts out its lab performance to Prisma Health. And today we've understood that Prisma Health is able to run the IgG antibody testing. Now, there are 2 broad groups you can classify antibody testing to, the qualitative and the quantitative, but there are different methodologies. The ELISA is one of the commonest one people use, and that can do both qualitative and quantitative assays. The chemiluminescence test can be partially semi-quantitative, and the one that we're hoping to be able to do at Kershaw Health is initially going to be qualitative IgG testing, then followed after some weeks with progress to quantitative. The lateral flow assay is the process that they use for most of these rapid kits that are distributed about. And those are the ones that actually have the most challenges, because they tell you the sensitivity and specificity is a certain range, but you don't know the prevalence. And as already earlier discussed, these can have a big impact on whether those are really the true sensitivity or positivity rates. Then the gold standard for measuring the antibodies will be by the plaque reduction neutralization titers, which cannot be done easily. It's a very cumbersome process. So that's the machine that we have in Kershaw that we want to use with the chemiluminescence assays. What are the potential uses of antibody tests? As already been earlier elucidated, it can enable us to know the actual or the true prevalence in the community. You can also use it for surveillance, and that can help with policy decision making. For example, can children return to school, or can they not return to school yet? Obviously, if you have a lot of immune people, you are not so much as worried as if you don't have a lot of immune children. And recently today, we just heard that the school has been closed till the end of the session, till next academic year in South Carolina. So if we had had this good antibody quantitative testing with all the parameters well defined, whether the antibody protection is there, whether these are actually neutralizing antibodies, how long does the protection last for, that may have helped in guiding the decision making rather than making a blanket decision in this case. But of course, since that data is there, they don't have any other choice. So that is one definite area this can be used. Another area that it can be used is actually derived from a Chinese paper that I saw in CID, where they looked at the antibody response in SARS patients in China. And they found out that patients who were tested with the real-time PCR tend to have loss of the sensitivity of the real-time PCR by day 7. However, if they combine the antibody test with that, they may actually increase the ability to diagnose SARS-CoV-2 in those patients. So that's another area where it can be potentially used. And obviously, we've talked about convalescent plasma transfusion earlier. And again, it could be reassuring just to know that the patients that you are going to give the convalescent plasma have a certain amount of antibody in their system. Right now, this is not being measured quantitatively. Most of the tests are all qualitative tests, but if we can get to a point where we can define whether these antibodies are neutralizing antibodies and what amount is protective, we can actually know and screen patients before they are used for plasma donation. But just knowing whether they have antibodies or not and whether they have IgG or not will actually help in reinforcing the belief that the convalescent plasma will be useful in such patients. Right now, what the guidelines we're using is we're looking at patients whose last test is 28 days out from the time they're going to use their plasma at the very least, and hoping that by then they should have formed the antibodies by that time. In that same Chinese study, it is mentioned that the IgM usually is formed by day 8. The IgG is usually formed by day 12 to 14. So using that 28-day window is not completely wrong, because most times all those antibodies, either IgM or IgG, will have been formed by then. And also, it can play a role with vaccine development, because in areas when you have the vaccines being produced, you want to know those who are already immune and may not need the vaccine and those that need to still be vaccinated. And at times you wonder whether patients that received plasma donation or convalescent plasma treatment, following that treatment and recovery, do they still maintain enough innate antibody production? And will they still be candidates for vaccination? These are some of the things one can use the antibody test when it's further developed to define. Then there's also the possibility that it may play a role in prognostication. One of the studies on this antibody quantitation via the ELISA methodology suggested that in patients who have very high antibody titers, that tends to portray a poor prognosis in their own cohort. Maybe that may be an indication that those kind of patients had a severe cytokine storm in such cases. So all these uses will be in a way helpful to define the population better. The only challenge though is that there are so many antibody tests out there. There's apparently no well-defined regulation yet. Only 4 companies have been given emergency use authorization by the FDA. All the others are just allowed by the FDA to sell their products, but they don't have any form of validation, and they do not have any prevalence numbers to back up the numbers they are spewing out for the sensitivity and the specificity of those tests. So in a way, it's like the Wild Wild West. People are just selling whatever kits they want to sell. The danger for this may not be for this group, because people in this group kind of know what they're doing. But you can imagine if you go to smaller areas or where you don't have people who specialize or are interested in this kind of subjects, they will present to them a test that has a sensitivity of 95% or 90%, specificity of 90%, and they will run with that, not knowing that there's some important missing factors. One, you don't have the prevalence. 2, when you report or when they report those sensitivity and specificity results, they're not telling us from what time of onset of symptoms was that calculated. Because obviously, if you are calculating way out for an IgG test, you may have a higher sensitivity and specificity, and all those can skew your interpretation and results. But one of the things, some of the things that makes the antibody test kind of attractive is that large number of tests can be performed and you can get a faster turnaround time at a cheaper cost. So you can actually study a large group of population and quickly get your results. So those are some of the areas we considered using the test in our facilities. It does have some limitation. Number one, it's not a real-time PCR test, so it does not determine infectivity. It may tell you that you've been exposed, but it doesn't tell you whether you're still infectious or not. And there are still some accuracy issues, like I alluded to earlier, issues with regards to the real meaning of 90% sensitivity or 90% specificity in the absence of prevalence. Also, whether this test or the antibodies that you detect from this test, what do they really mean? Are they neutralizing antibodies that confer protection? And how long will they stay in the body for? From experience with SARS and MERS, it's reported in the literature that it could stay anywhere between 6 months to over a year. Well, the implication for that, though, is that will people be requiring intermittent vaccination to maintain immunity? Because as we know, there are some viral infections that will confer pretty prolonged immune duration. For example, chickenpox. Meanwhile, there are others whereby there is limited immune protection until the titer drops again. So those are things that will have to be checked and looked into. The FDA reviews, like I said initially, only 4 companies have the EUAs, emergency use authorization. All the others are just running by night with very sketchy data at times. Some may not belong to this category, but a good number of them fall into that. Even by just looking at the pamphlets that they're giving you, you will have a good idea that what these guys are saying may not be absolutely correct. Now, the other concern with the limitation of the test is that when you get false negatives, you may be getting false negatives. This may be as a result of too early testing. Like I said, in the Chinese study, most of the antibody formations were after 7 days. IgM was after 7 days, around 7 days, 7th day and 8th day. And the IgG was about day 12, though all of them were formed by 2 weeks. So that can be useful in knowing. And lastly, false positive results can also be a problem, especially if there's concern about cross-reaction with other strains of the coronaviruses. Of importance is whether the test you are doing is quantitative or qualitative. I mean, quantitative tests will give you more information and you can actually derive a better plan from the information you get from qualitative information, from quantitative testing. Qualitative testing, on the other hand, will give you some information, but you really don't know what to make of it. For example, someone that has now a positive qualitative IgG test, it's difficult to tell that person, don't put on PPEs or you are immune until we have more data based on quantitative testing. Just like Dr. Meisner alluded to earlier, that it's mainly for research purposes right now. So I will just use this to illustrate one of the problems with when people come with this test and they tell you, oh, it's 90% sensitive, 90% specific without knowing the prevalence. So let's say we have a population that has a 5% prevalence and you have, for ease of mathematical calculation, you have 1,000 people in that population. So that's what you have there. Well, we made these assumptions. You have a first scenario where you have a prevalence of 5% and the sensitivity of 90%, specificity of 90%. Okay, so if you want to know or estimate the number of the disease in the population at 5% prevalence, that should be 50. If you go ahead knowing that 50 is the number that have the disease, 950 don't have the disease. When you look at the test sensitivity, at 90% sensitivity, that means 45 of the 50 should be picked up by that test. And the specificity, if you look at the test results to 90% specific, 855, which is 90% of 950, 855 of them will not have a positive test result. Then when you fill in your spaces, you have 5 with the negative results who do have the disease, and 95 who do not have disease but have a positive result. So you can, from this way, calculate your calculate your positive predictive value. And that positive predictive value, when you calculate it, will turn out to be 32%. And that is really not good. Meanwhile, when you take this test to your regular primary care provider, who is doing the hardest they can do at managing these patients, when they tell them and say this is 90% sensitive, 90% specific, has 90% specificity, they feel empowered that this is a test that they can use, especially the rapid kits. But in truth, when you analyze everything, it probably does not perform as well, especially when you have low prevalence. And the true prevalence of this disease in the United States is not known. Hopefully, with the development of more antibody tests, we may be able to screen and survey more people and get it true prevalence. But what that just tells me is that one has to be careful when you are getting bombarded or informed about doing some of these tests. The same thing at 20% prevalence. I'm not going to take time running through it, but I'll just tell you that with increased prevalence and with the numbers filled in, the positive predictive value will be much better. So that leads us with the problem that we're having now, that we have all these tests being advertised all over the place, that they are pretty specific and pretty sensitive when they don't have the information that is being given to the providers. One of the things that the FDA have asked all these vendors to do is to make sure that they say or put in their results that, number one, the tests have not been reviewed by the FDA. Negative results do not rule out SARS-CoV-2 infection, particularly in those who have had contact with the virus. And follow-up testing with a molecular diagnostic test is recommended. Also, results of antibody testing should not be used as the sole basis to diagnose or exclude SARS. And positive results may be due to past or present infection. So this shows that even at this point, obviously, since the FDA has not reviewed all these tests, they do not have a lot of confidence in a number of them. And like I said earlier on, there are again over 70 companies who are pushing out these tests all over the country. Some of them really know what they're doing, but a good number of them do not really know what they're doing, or they're trying to be mischievous. So that was why at the beginning of my slide, I said antibody testing, to test or not to test. But we believe that what we are going to use is pretty going to be a standard test, and we can follow the directions and get good numbers to know where we stand. So for now, what we want to do is use this test on convalescent plasma donors, then also use it on our frontline staff, and also patients who were admitted and we suspected that they had the infection, but they test negative. Maybe those will be some of the patients we can do the antibody test in conjunction with the PCR test to see whether they are truly infected or not. So I will stop here and take your questions if you have any.
Just to confirm, Dr. Olatosi, the actual test that we are doing, is this the CellX test or which?
No, it's not the CellX test. It's actually a chemiluminescent test. It uses a principle similar to ELISA, but it's more of an immunoassay linked test. And they use this machine. This is a smaller version we have in a smaller hospital, but Prisma has a bigger machine. This is the same machine that runs the chemistries, but it also runs the HCV antibody test, pregnancy test, and all those kind of tests. They just have to have the right kit to slot in place. These areas there, that's where they slot the test, the blood samples, just in the space right there in the machine. And it's an automated machine. They don't really have to do much. Once they get the blood sample, they come in vials and they slot those vial racks in there, and it's automated, and it gives them a detection rate. And the result is binary. It's either positive or negative. That's what you get. Again, that is not the best. That is not what you want for, but it's something to use at this time, because really what you will need eventually is to have a way to quantitate the antibodies that you are getting, and whether those antibodies are effective, and that is whether they're neutralizing antibodies and they confer protection. Actually, the best way to do that will have been by a plaque reduction neutralization assay. However, the problem with that is that that's very cumbersome and time consuming, and they can actually make some errors with that also. But really, that will be the gold standard.
Thank you. Any other questions for Dr. Olatasi? Okay, fantastic. Well, if you think of other questions, you can also post them in the chat. We can talk about them there. Dr. Olatasi, thank you again so much for coming out to talk. I think serology is going to be very interesting to see what kind of utility it has moving forward. It's got a lot of potential. I think at this point, we're going to move on to our next speaker, Dr. Keith Barron, who's going to be talking a little bit about possible imaging modality that might be useful here. So I'll turn it over to him. Thank you, Dr. Barron, for coming.
Thanks a lot for having me, and I appreciate you inviting me to do this. So I'm going to talk about lung ultrasound for diagnosing COVID-19. Briefly, I'm an internist. I work as a hospitalist clinically, but I also run our point of care ultrasound program at the University of South Carolina and Prisma in Columbia. So the objectives here are not to make you a radiologist or even know exactly how to do lung ultrasound, but I'm going to go over some of the ways that lung ultrasound can diagnose viral pneumonia, and particularly COVID-19, and then also discuss some possible strategies for incorporation of lung ultrasound into management of suspected or confirmed COVID-19. I put this picture up here of several new ultrasound machines. So for those of you who are not aware, there's been a technological revolution over the past 2 decades in ultrasound imaging. And so most of these devices now hook into your smartphone or tablet, or have an associated tablet sized device with it. And so this is really attractive in the current crisis when, it takes a lot of time to take a chest x-ray into a patient's room or to bring the patient to a CT scanner. And so ultrasound has proved to be quite accurate in diagnosis of pneumonia, more sensitive and just as specific as chest x-ray. And so this is a very attractive imaging modality that the provider can bring into the patient's room and perform this in real time with the patient. So given this is a case conference, I put this up here. We've all seen chest x-rays in patients with COVID-19. So this woman came in, this was her initial chest radiograph. She had fever, cough, and hypoxia. We see some subpleural opacities. And her CT scan obtained during her course in the intensive care unit showed subpleural ground glass opacities and consolidation. And as we know from reports in China, and also as we're discovering ourselves, that most of the patients who end up developing COVID-19 pneumonia have diffuse, multifocal, peripheral, subpleural consolidations and ground glass opacities as well. And so from the very beginning of this, lung ultrasound has been used to diagnose this disease. And so this is one of the first reports showing that there are several abnormalities, both at the pleural line and imaging some deeper consolidations that indicate COVID-19 pneumonia in patients infected with SARS-CoV-2. And this paper is comparing it to CT findings. And just like CT, the distribution of these findings is pretty similar, given that I'm not going to get into the physics of ultrasound, but given that most of these lesions are peripheral, it makes it very attractive to image with lung ultrasound. And given that these consolidations often abut the pleural line, we can image these quite well with ultrasound, particularly in the posterior or dependent areas. So most of these protocols call for imaging multiple intercostal spaces. And in this case, we're using a low frequency probe, but you can use a high frequency one as well. And so there are multiple different protocols described. but I like to think about it like physical examination with the stethoscope. Each intercostal space you examine with ultrasound is similar to an intercostal space you listen to with your stethoscope. And so you're painting a kind of a mental map in your mind of where you hear crackles or where you see findings on lung ultrasound, kind of putting together a composite image as you go. Very, very briefly, this is a lung ultrasound home screen. For those of you who have looked at other ultrasound images like kidney or the heart, this can be quite confusing. And the problem is that a tissue-air interface generates multiple artifacts on ultrasound imaging, but the change of these artifacts can help diagnose underlying pathology. So this is a patient. This is the same patient that I was talking about, or I showed the case of before. On the left, we see a normal lung field. This is an intercostal space anteriorly. And on the right, you can see that this is a different, was a different intercostal space. And what we're seeing is these vertical artifacts that arise from a pleural line. And we have a very irregular pleural line as well. And that's characteristic of a viral process. And what we're seeing here, the blue here highlights what are called B lines, or a marker of interstitial syndrome. And I'll talk about how these are non-specific in a minute. But the way I like to think about this is that they're like crackles. So anytime you hear crackles on physical examination, you will see B lines, although the inverse is not true because these are quite sensitive. As the disease progresses, the B lines start to fuse, and you see confluent B lines. So these vertical artifacts fuse, and it becomes a vertical white kind of mass here. This blue area is somewhat representative of that. And then as the pneumonia progresses, you see these areas of subpleural consolidation. And on ultrasound, it appears as a darker, almost shredded area below the pleural line. And this is our patient. And so we're seeing these same findings. So we're seeing B lines that are starting to fuse. We see a rib and a rib shadow, rib shadow, pleural line, and multiple fused B lines. And characteristic of a viral process, we're seeing some areas that are spared as well. But this was quite evident, and this corresponds directly to where she had ground glass opacities on the CT. So as far as the sensitivity and specificity of this, it's not quite known, although for diagnosing regular pneumonia, ultrasound has about a 90% sensitivity when compared to CT, and 98 to 99% specificity when compared to CT. This is one of the original reports showing that in every single patient that they compared to the ultrasound findings to CT, they had some degree of abnormalities. And I'll tell you that of the 15 or 20 or so patients that I've imaged, every single one of them had diffuse opacities as well, at least of hospitalized patients. So putting it all together, it's quite sensitive, but it's not specific. And the reason why it's not specific is many of these findings can also be found in other processes, such as ARDS, cardiogenic edema, and pneumonia. But what it is it's quite sensitive. And so if you have a patient with respiratory distress and you don't see any of these findings, that it would indicate another process, possibly asthma, COPD, or potentially pulmonary embolism. And so, you know, the question we have right now is, do we need to image all of these patients? And so this is one article recently published in Radiology. And their summary is that it's not routinely indicated as a screening test for asymptomatic or mildly symptomatic patients unless they're at risk for disease progression. But these recommendations are mainly based on the fact that getting a chest X-ray into a patient's room exposes people and has some sort of, somewhat cumbersome. Taking them to a CT scanner is somewhat cumbersome. But if you are able to take that ultrasound probe into the patient's room and integrate it into your routine patient encounter, it makes you wonder whether these recommendations might not change. And in fact, that's what they were doing in Italy. And so I did some studying in Italy, and I talked to one of my mentors over there who was on the front lines in Turin. And what they actually did is they took the ultrasound probe into the emergency department waiting area when they were completely overrun, and they used that as their triage screening tool. And so I think that ultrasound becomes quite interesting in scenarios where you have limited access to diagnostic imaging, so resource limited areas, and also areas in which personal protective equipment is quite limited. Because if you already have to have a healthcare provider come and examine the patient, if that physician or practitioner is trained in ultrasound, then you potentially can use lung ultrasound to screen for diffuse lung findings. And so this is an expert opinion that's emerging based in some opinions in Italy, around the United States, and some of my colleagues in New York, and even some of our colleagues here in the emergency department at Richland are using an approximation of this. But essentially what you do is you ultrasound the patient. If they have diffuse lung findings, then you kind of look at the patient, assess them clinically. And of course, if they have respiratory distress or hypoxia, you would want to admit that patient. If they did not, then the diffuse pattern on ultrasound does probably have an increased risk for that patient to progress to a worsening respiratory status. So at the very least, you should do a risk factor assessment, consider close outpatient follow-up or even observation in the hospital, depending on comorbidities. If there is not a diffuse lung ultrasound pattern and the patient does have hypoxia or respiratory distress, you really should consider other etiologies of that hypoxia. For example, COPD, asthma, or pulmonary embolism. And if the patient does not have that pattern, they're not in respiratory distress, then at least in our emergency department, we're just discharging those patients home and do usual risk factor assessment. So in summary, lung ultrasound is well suited to evaluate for viral pneumonia, particularly in resource limited areas or if personal protective equipment is limited. I put this picture up here because this is a picture that I took, or one of my colleagues took, when we were ultrasounding each other on a mountain. These devices are quite accurate. You can take them anywhere. And a diffuse pattern of lung ultrasound really does require close monitoring or follow-up, particularly in patients with risk factors or hypoxia. Thanks a lot.
Any questions for Dr. Barron? Yeah, I got to say, it's getting harder and harder to even get a CT on a COVID patient these days. And some of them can be a little frustrating because those PCR tests, the nasopharyngeal swabs, certainly aren't perfect.
And for most things that we get CTs for, so pneumothorax, pulmonary edema, pneumonia, and several other things, ultrasound is more sensitive than chest X-ray and just as specific.
And then, of course, the other thing that people are getting more and more worried about in these COVID cases is clot, thrombosis. Potentially there could be a role for picking up something like that, maybe some right heart strain or something in the leg.
Yes, absolutely.
Okay, well, thank you very much, Dr. Barron. I very much appreciate it. I think this could be very useful. Really, really wonderful stuff. It's 8 o'clock now. We have one more talk. I'm going to kind of defer to Drs. Weissman and Justo. Do you want to proceed, or are you inclined to another engagement right now?
Oh, there's so much to do these days, you know. I thought I'd go out to the bars and hit a movie. I'm absolutely happy to go on. I think our presentation will be quick. It was just a little bit different in treatment, our experience with tocilizumab, if I say it right. I can add the slides, I think, or Adri did send them to her. Let me see if I can pull them up. Somehow I managed to get 1,000 more emails between now and Okay, how do I get back to Zoom?
Dr. Wiseman, I can try and see if I can give you remote control.
Let's see, because where is the part where, oh wait, share my screen. I think I can share it.
Yeah, go ahead and try to share. If not, I can go ahead and share because I've got the slides up.
Let's see.
Something's happening. There it is.
All right.
Okay, and let me say, I want to do it in slideshow. Play from start. Okay, there I go. Maybe, there I go. Okay, so this is going to tag with Julie Justo on looking at tocilizumab, and I practice saying in our sort of local experience using this for COVID-19. Just this is like, I love this slide because it's a very nice quick summary of the phases of COVID in the disease process. And if you think about the early phases, just the virus replicating and our body beginning to have a response to it. And then somewhere in this mid phase is the turning point where we start having a hyperimmune response to the virus and a hyperinflammatory response, often triggered by IL-6. So the goal when you think about using IL-6 inhibitor like tocilizumab is to try to find this sweet spot before they take off to this inflammatory response, but not so early because some people will never reach that phase, and you don't want to use this toxic drug, this expensive drug, this limited resource drug in people who don't necessarily need it. So we've used a lot of it now, and this is just a very quick summary. It's not a fancy study. It's a retrospective case series of our experience over 1 month time, our first month of our COVID outbreak at Prisma Health Midlands. We had just some quick baseline characteristics. So we use this in 19 patients. I think there's a couple more who've had it since then. And this is just a very quick summary of the patient's baseline characteristics. Mean age is 72, about half were men. Racial breakdown, 63% were African American, and that probably reflects our population. Mean weight, 97.7 kilos, so they were big. And mean peak temperature prior to our on admission was 102.4, with mean saturation on room air, well, not necessarily on room air, was 89. And as you can see, there's a breakdown of whether they used nasal cannula, they were intubated at baseline, or had room air. Just X-ray findings. So all of them had an X-ray. All the patients had some sort of findings at baseline. Most had interstitial abnormalities. Speaking of having problems getting CAT scans, 2 had a CAT scan, and they had findings, not surprising. 63% of the patients were admitted from the emergency room to the intensive care unit, and 47% of them were on pressors at baseline. So this was a sick population at baseline. I'm showing you here the baseline inflammatory markers from interleukin 6, ferritin, C-reactive protein, LDH, D-dimers, and procalcitonin. I want to tell you that none of these interleukin 6s were available at the time that we started the treatment. These are send-out tests. They took a long time to get back. And most individuals had 1 dose of tocilizumab at 400 milligrams. 1 had 2. Mean time to start the tocilizumab was 4.7 days from the time of the test, but from the time of their admission was 2.5 days. And some of this reflects the delays we were having early on in getting test results back. So we didn't necessarily know they had this. And this just shows a breakdown of all 19 patients from patient 1 through 19 of their baseline IL-6. Again, we did not have this laboratory data at the time that we were giving the tocilizumab. But you can see it's quite all over the place. And I think it will be interesting at some point to look back at the differences based on those who had low baseline IL-6 and those who had high IL-6 when we look at some of our outcomes. And at this point, I'm going to let Julie take over and show some of the clinical outcomes and then quick discussion.
So we decided to look at poor clinical outcomes first. In-hospital mortality was noted in 8 of the 19 patients, so 42%. And transition to hospice was noted in 21% of the cohort, 4 out of the 19. So if we put those together, either in-hospital mortality or hospice occurred in 9 out of 19 patients, or about 47%. In addition, intubation post-tocilizumab, so we were hoping toci would actually prevent that, but we found that intubation was still necessary in 3 out of the 10 patients that were not already mechanically ventilated by the time they received toci, and about half, at 47% of the patients in the entire case series, ended up needing renal replacement therapy post-toci. Again, so signs of some continued organ dysfunction. Next slide.
I'm failing.
So then to look at the other side of things, we tried to look at signs of clinical cure, and we roughly defined clinical cure as either hospital discharge for the patient or having a SARS-CoV-2 PCR that was negative for 2 days in a row with clinical improvement in symptoms. And a follow-up was either death, transition to hospice, hospital discharge, or the end of the study period, whatever was sooner. Based on those definitions, we found that clinical cure was not obtained in the majority of patients in 58% of the case series. Only 16% could we actually confidently say achieved clinical cure, and then 26% were unknown, mostly because they were still in the midst of their hospital admission. Next slide. So looking briefly at some of the inflammatory markers, as you saw, most of the inflammatory markers that were noted at baseline were elevated for most of our patients. Ferritin was monitored at least twice in the majority of patients in the case series at varying time points after receipt of tocilizumab. So that first dot is baseline, the worst value that was noted. Follow-up 1 and follow-up 2 were the next most recent levels that were drawn of ferritin immediately after toci was administered for each patient. And what you'll see is that each line represents its own patient, and it's kind of all over the place. We would have hoped to have seen a more general decrease in ferritin with follow-up 1 and follow-up 2 levels. This figure does exclude one outlier patient, patient 4, who had a baseline ferritin that was extremely high. So we just pulled that one out of the graph because otherwise it would have made everything else difficult to read. Next slide. Now, unfortunately, C-reactive protein looks a little bit better. You can see if you're looking at all 19 patients, there's a slight potential for a decrease in CRP with follow-up levels 1 and follow-up levels 2. Again, not every patient had this, and they certainly weren't all taken at the same time period. We can tell you most of the follow-up levels were received as soon as 12 hours after the toci and up to kind of like 3 days after the toci. So you can see maybe there's some signal that C-reactive protein went down. Next slide. Lactate dehydrogenase was the third inflammatory marker that we had a fair amount of data on. And you can see, unfortunately, these data are all over the place. If anything, maybe there's a slight increase in lactate dehydrogenase for this case series. D-dimer, that's okay, you can go forward. D-dimer, unfortunately, I was actually going to hide this slide because I think it's really difficult with the limited data that we had in the case series to pull much of anything from our follow-up levels of D-dimer. Next slide. And the same holds true for procalcitonin. We haven't seen very elevated procalcitonin levels in our COVID-19 patients. Next slide. And I'll turn it back over to Dr. Weissman to wrap it up.
So just a quick discussion. Generally, we were giving this tocilizumab to very severely ill patients. We were giving it relatively soon after their admission, but not so soon necessarily after their diagnosis, and that's in part because there was a delay in getting test results back initially. Our clinical outcomes were not very good. We had more than 50% mortality or hospice, very low clinical cure rates, and very high rates going on to intubation or renal replacement therapy. And the inflammatory markers were generally all over the place. I do believe that probably one of our problems is that many of the patients were getting this too late when they had already had that cytokine storm. And if we had a way of better figuring out that moment, that sweet moment before they went into that cytokine storm, we might have had better outcomes. But I think we're now on to newer and hopefully more successful therapies. And just obviously there's a lot of limitations to this. This is just a case series. We don't have comparator groups. It was retrospectively open labeled. We were probably giving this to the sickest patients because of the limited supplies we had, and all the usual co-founders, including issues around whether or not we used optimal dosing. And I'll just end with a moment of questions. And I just want to say to Edwin that you're going to have to rename this conference statewide, because 2 months in a row now you've had representatives from across the state.
Well, that's partially because of you. Thank you for helping get in touch with these wonderful people. Everyone loves talking about the COVID these days. I don't know why. Dr. Weissman, do you think there could be a role for potentially, like you said, finding the sweet spot for tocilizumab is difficult. Potentially the folks that we're seeing that are high risk before they go downhill. This is all I do now.
That's a difficult question, because especially now that we're talking about using some other like presumably direct acting agents such as remdesivir or convalescent sera, I think we just don't really have the answers yet, and more data will come out, and so much information is coming out without any true peer review, randomization, good controlled studies. It's a little bit hard to sort through it all.
I think the other thing
I at this point have my money more on some of the convalescent sera and other agents that we have coming out.
I agree with Dr. Weissman. I think the other thing to consider too, if we had the capacity to have a same-day turnaround for IL-6 or IL-6 in-house, that would potentially be a way that we could operationalize this, because then you would have a mechanism of saying, yes, this patient has an elevated IL-6, this drug has a hope of working. So having that long turnaround really kind of handicaps us in trying to protocolize this into a treatment guideline. The other thing to keep in mind too is that there are potential toxicities with this agent in terms of LFT elevations and potential for subsequent infections as well. And we're not even sure that we're giving the right dosing because we have a lot of larger patients in the state. So there's a lot of unanswered questions that start to make the benefit to risk ratio seem a little bit less favorable than some of the other experimental therapies that we currently have.
And lastly, I will add that all these patients did receive hydrochloroquine and zinc, and some also received azithromycin. We saw a lot of arrhythmias. Given some recent data on hydrochloroquine, we wonder maybe that was contributing to some of our bad outcomes. And we also did see a lot of elevations in liver function tests.
Yeah, I would say, again, just by looking anecdotally at the data set, the majority of the patients were on at least one experimental antiviral agent. A few were using systemic corticosteroids, though.
Okay, great. Any other comments or questions before we close out the meeting? Thank you both very much appreciated.
Thank you.
Can we all agree on when the peak is going to be?
It's going to be in the fall. with influenza.
Which year?
Yes. Yeah, right. That's Carrie in the background.
Good question. Robert here. There will not be a single peak. It will be a gradual peak with a plateau lasting at least 2 to 3 weeks, during which summertime will trigger mass gatherings, and hence in the fall, a second wave or second peak.
Yeah, I'm afraid that's the most likely prediction, even though our crystal balls are pretty cloudy.
It seems to me that
mine's been pretty clear.
That we're at sort of a steady state. People ask me, is it going down? I say it's not going down, it's just not going up. So it's a sort of a slow burn at this point.
We need to do a lot more testing around this
Yeah.
to really know.
I'm concerned that we're gonna have a spike again in 2 weeks. With the opening yesterday, our clinic waiting room had about 20 patients. Everybody came to clinic. The beaches you're seeing the pictures of the people. So, and the supermarkets are even busier now. So 2 weeks.
A little longer.
It's in 2 weeks.
2 weeks will be the next spike, not a decline.
We'll see if we can put together some kind of a fantasy football league and people can put down their bets.
Got it.
Well, thank you all so much for coming out and being a part of this. It ran a little bit late again, but I think it was a lot of very interesting and hopefully useful information. We'll see what comes next. But I think we've got some good things to look forward to. We've got a lot of very smart people working very hard to figure this out, and you're some of those people. So thank you all for the work that you're doing. It's very much appreciated, and I look forward to working alongside of you moving forward.
Great, thank you.
Thank you.
Okay, I'm still not out.